So, good afternoon. Before I introduce our speaker for today, we have a change in the schedule this afternoon that you should appreciate. We will be, people here in Little Rock, you will not move out of this room, and we will not be going over to IDOD at 2 o'clock for the lab over there. What we're going to do is actually do the entire lecture and the cases and all the practice here in Little Rock in this room. And Northwest, I think you've already been instructed that at 10 till, we're going to take a 10-minute break. And Northwest, you're moving over to P17, I believe. We'll come back at 2 o'clock. We'll take a 10-minute break on both ends. We'll come back in at 2 o'clock. And we'll wrap up with the activities and exercises for lab in the classroom, and we'll probably be done around 2:30, no later than 2:40, okay? But we'll be in here the entire time. Today we're talking about the musculoskeletal system, and I'm happy to introduce one of the UAMS pharmacy practice residents, Mallory Link. She's a graduate of UAMS College of Pharmacy last year. She's doing her PGY1 pharmacy residency here at UAMS this year. I'm sure some of y'all have met her through recitation and other things over the course of the years. If you have any questions for her about why she did a residency and what she got out of it and what she liked or did not like about it, she'll be happy to answer those questions at the end of the lecture, or you can come up to her after the lecture's over and get her information and or ask her questions now. She'll be happy to talk about those. And she's going to be talking about the musculoskeletal system today. So I'm going to turn it over to Mallory.
All right, thank you. Okay, I may have to, thanks. I may have to hold this up for a little while for the majority of it. So like Dr. Thomas said, we will be incorporating lab into the lecture. So in order for that to work out to everyone's benefit, we'll have to, participate a little bit more than most lectures, but hopefully that'll give you an excuse to talk in class, to laugh in class, and to get up and move around in class. So maybe it won't be as bad as maybe you're imagining. So you had therapeutics test yesterday. How was it? I'm getting a lot of this. I'm getting a lot of just this. Okay. That's you. I apologize. I apologize. I'm very sorry. That's true. So you're all in a daze today, correct? Okay. So first of all, I'll tell you about my morning. So I have this friend that's been trying to get me, super athletic friend, first of all. She's been trying to get me to go to boot camp. She's like, Mallory, come on, you got to get to boot camp. Like, you can do it, no big problem. And I'm like, well, first of all, 5 a.m. does not sound like fun. I hate 5 a.m. Second of all, boot camp just sounds miserable. I don't want somebody yelling at me, to get up and do stuff. But then the longer I started thinking about it, I thought, okay, my friend, she's about 20 years older than me. She's in really good shape. She's in way better shape than I am. And so I thought, okay, well, you're older than me and you're in way better shape than I am, so I might as well give it a shot. So this morning I go for the very first time. Never been to boot camp. Who here has been to boot camp? A boot camp of any sort? A few. So it's no joke, first of all. Second of all, they don't really yell at you the whole time, so that made me a little bit happier. But I go today. First of all, I was late because I had to get up at like 4:30. I was late getting there, so I had to run to catch up because they had already started. They were like halfway down the river by the time I got there. So I finally catch up, and I realized that we're doing cardio today. So it was all like running and stairs, and so we did a lot of stairs, like more stairs than I've ever done in my life. Like I feel good about myself when I take the stairs to the 6th floor. I feel good, and I'm like huffing and puffing by the time I get there. And so today we did that. So the moral of that story is that I'm already starting to get sore. And so, it hasn't even been like 24 hours yet, so I'm really going to be sore tomorrow. So this afternoon and this evening, when I go to your pharmacy and tell you I'm hurting and I need some drugs, and that way, after today's lecture, you'll be able to know how to assess me appropriately and give me the good stuff. So I want to approach this lecture from the retail standpoint as well as a clinical standpoint. And that way, hopefully, no matter what avenue of pharmacy you're getting into, you'll at least see a little bit about what pharmacists do in that aspect. From the retail standpoint, You will interview patients and things like that. From the clinical standpoint, I'll show you how I go about approaching a patient on morning rounds and looking up labs and things like that. So hopefully there'll be a little bit for everybody. Okay, you guys can't see my slides. Anybody know how to make it to where? Push PC. Somebody started talking. Good? Is that what they should be seeing? Okay. Okay, so throughout the lecture today, we will list and define the functional roles of the musculoskeletal system. So why do we have the musculoskeletal system and what does it do? Second, we're going to differentiate between localized and systemic disease and the differences between those. We will list and describe different types of abnormal joint functions. Through that, I'll show you how to figure those out and how to assess them. We're going to list drug-induced conditions, and so we'll talk about the drugs that can cause them, and we'll give examples of them. And then lastly, this is kind of the big one that we'll spend quite a bit of time on, is determining our role. What do we do as pharmacists? And so first of all, I've made the slides to be 4 on a page for 2 reasons. First of all, that will allow you to see the pictures better and the images better and some of the smaller words. And then second of all, it'll allow you to write stuff down. So throughout the lecture, you will have to write a little bit. Mostly it'll be, some of the stuff I talk about, but I want you to write down how to ask the questions to your patients. How do you ask about their pain? How do you ask about their weakness and their fatigue? And in a way that they understand, in a way that they will give you the answer that you want. Okay, so the musculoskeletal system forms the framework of the body. It consists of 206 bones and over 600 striated muscles. So those are the voluntary muscles that we control. They're held together by tendons and ligaments. So tendons, if you remember, maybe from A&P or something, but tendons connect muscle to bone. Ligaments connect bone to bone. And so we've got those as well. And the musculoskeletal system provides 5 main functions. So 5 main functions. The first one is to support the body. So the musculoskeletal system allows humans and animals to stand up strong and not just be, blobs on the floor. So it allows us to stand, gives us support. The second thing it allows us to do is to move. And so because of our muscles, we can move back and forth and do whatever. The third thing it does is protects vital organs. Protects. So, for example, our brain is protected by our skull. Our lungs are protected by our rib cage. The fourth thing it does is it produces blood cells, whether that be the marrow or whatever. And then the last thing it does is it stores certain minerals like calcium and phosphorus. And that's mainly the skeletal portion of the musculoskeletal system. So I'll repeat those. Again, 5 main functions. It's support for the body, movement, protection, produce blood cells, and storage of certain minerals like calcium and phosphorus. Okay, so musculoskeletal complaints are the leading cause of healthcare visits in clinical practice today. They account for about 315 million visits per year, and nearly 20% of all the visits in the U.S. are from these kind of complaints. Lower back pain ranks 5th among the clinical issues, and the 2nd most common problem among patients seeking care. So it's a pretty big deal, and a lot of patients at some point over their life, and I'm sure you will too, will have some of these musculoskeletal complaints. So when approaching a complaint, the College of Medicine looks at 4 different ways to assess their patients. They do inspection, palpation, auscultation, and percussion. As pharmacists, we will focus mostly on inspection. So we're going to look at what's going on. We will look at the joint. We will look at someone's gait to see if they have trouble walking. We will look at, the issue. Is it warm? Is it swollen? What's going on? Their range of motion, is it limited? And so inspection is a big part of what we do. Palpation we do sometimes, mostly with joints. If somebody complains of joint pain or like fluid in the joint, we can do that. Auscultation, we really only do if we're going to listen for crepitus in the joints, and we'll explain that a little bit more later. But percussion, as pharmacists, I've never done it, and so we don't really use that as pharmacists too much. Those are all objective assessments. The biggest thing that we do, aside from inspection, as pharmacists, is the subjective portion. So we need to talk to our patients. We need to figure out what's going on. And that's what we'll spend the majority of our lecture today on. Okay, so the joints. This shows the different kind of joints in our body. The joint is the basic functional unit of the musculoskeletal system, and it forms a union of two or more bones. And so the degree of mobility within the joints can vary from all the way to no movement to full range of movement, depending on the structure of the joint. So movable joints are called synovial joints, and then they're classified by the movement. So we'll talk about that. So the ankle, for example, the ankle and the elbow are hinge joints, the elbow in particular. So no matter where I move my arm, it's just a hinge, just one motion. That's all it can do. Versus the shoulder, which is a ball and joint. And so it doesn't matter where I move the ball and joint, the hinge stays the same. Does that make sense? So the shoulder is a ball and joint. The hip is a ball and joint, or a ball and socket joint. I think I've been saying that wrong. We can look at the saddle joint. That's the thumb. So everybody do this. Northwest. They're like, oh, I thought you forgot about me. Okay. And another little cool fact. What's the largest joint in the body? Any guesses? The knee. The knee is the largest joint in the body, and it includes the femur, the tibia, and the patella. Okay, so at this point, this is the first of our lab assessments, and so this is one of our lab objectives is to practice palpating joints. And so just like you would in lab, find a partner, and you can stay kind of close. I need a volunteer.
I'm already pushing your button.
We'll do it.
Thank you. I need a volunteer from here.
Oh, we're not good enough for you now, huh?
I apologize. I'm sorry. I apologize a lot today. Can I please have a volunteer from Little Rock? I have one up here. Okay. I'm sorry, Carrie. You've been trumped. Okay, so what we're going to do, go ahead and just stand up here for just a second. What's your name? Sean. This is Sean. For any of you guys who don't know Sean, this is Sean. Okay, so I'm going to show you first about the 3 joints, and then we'll give you like 5 minutes to practice. And you pick your, oh my gosh, I got scary face. So pick your partner and let one person practice, and then you can swap and let the other person practice. So let me get this where I need it. I can't do that, though. Maybe I can. Okay. Can you guys still hear me or no? Northwest, can you hear me?
We can hear you, and I'd also like to point out that Sean is an award winner, so be careful with him.
Okay. So the first joint that we'll talk about is the temporomandibular joint. That's the jaw. So when you're assessing your patient's jaw, thank you for volunteering, you want to put your fingers right here at the hinge of the jaw. You're doing it yourself, aren't you? And so that's right in front of the lobe and the tragus on the ear. So you put your fingers there, and at that point you want to feel for deformities. Asymmetry is something going on that doesn't match the other side. You want to feel for warmth. Sorry. And then after that you say, okay, open and close your jaw. Do it again. Okay, so I don't know if you guys can hear that. So he has some crepitus in his jaw. So you want to listen for crackling or popping, which could be a sign of a few things. It could be a sign of disease, or it could be a sign, or it could mean that simply your patient like clenches their mouth when they sleep at night. So that kind of thing. Mine does it too, by the way. You want to feel for deformities when they move, and then also anything else that seems out of place. So we'll practice that. The second one would be the knee. Let me get a chair. I know. I said this was more interactive, correct? Okay. All right, sit down. Okay, so the first thing you want to do is look. So you look with your eyes. Look at the knee when they say their knee hurts. Is it red? Is it swollen? Anything look out of place? Is there a patella like way over here? So what's going on? The second thing you do is you want to feel around. So you feel around on it. Is there any fluid? Do they have any fluid going on there? Any bone spurs, any other kind of deformities? And then have them go move your leg like this. And when they do, you want to feel, is anything sticking out funny? So we're going to do that as well. The third one is going to be the shoulders. And so what you'll do is you'll stand in front of him, but I'm not going to do that, is you'll put both hands on their shoulders like this. And the first thing you want to feel for is, are they even? Is there asymmetry? They got something going on? Asymmetry. Second thing you want to do, is it warm? Is it swollen? Is it infected? That kind of thing. And then go ahead and move your arms like this, up and out. Go ahead and do it with both arms. And so then you want to feel, again, for any bone spurs, deformities, anything that just doesn't seem right. Any questions about that? Okay, so practice with your... You can go ahead and sit down. Thank you, Sean. I appreciate it. Okay, so practice those 3 things with your lab partner, or your partner sitting next to you. I can see. Are they being silly?
I'm going to turn your volume up. Hey, Seth.
Okay, Northwest seems to be wrapping it up. How are we going here? Is everybody about done?
Do you know how to turn her volume up on this speaker?
All right, I think so.
Because she's awful quiet on the speakers here.
Northwest, were you successful at palpating joints? Way to go.
Who's that? Who's that? Okay. I'll expect nothing like that again. Thank you.
Are we good on the volume? Do I need to okay, I can keep holding. I can keep holding it. That's fine. Okay, so I've heard that Northwest is having trouble hearing me, so I'm going to try to talk a little bit louder and keep it a little bit closer. So palpating joints, what do you think? Can you do it as a pharmacist? Yeah, I think so. Everything from my point of view, everything looked great. You guys did well. Okay, so you successfully completed. Yes?
I was wondering, on the shoulder one, are we supposed to be feeling like over the joint or more on the muscle? Does that make sense?
I would do more like right here because of what you're feeling for. You're feeling for asymmetry. It's like either like this. What's going on. So the question was, where do you feel? Do you feel here or do you feel out to the side? And so if it depends on where their pain is. But if you're just feeling
Can you show it again? The camera wasn't on you when you did it.
Yeah. Can you see me from here? Uh-oh. Okay, so closer to the neck, if they're just complaining of shoulder pain. If they're complaining like, hey, my upper arm hurts, then maybe the joint. But checking symmetry between the two arms and the shoulders would be more on top. Does that make sense? Okay. All right. Okay, so the biggest part of assessment, aside from the palpation of joints, would be talking to our patients and trying to figure out really what's going on. So does this slide look familiar to you guys? Yes, I hope so. The basic 7. So if you remember the basic 7 questions, you can alter them for specific complaints rather than having to try to memorize a completely different set of questions for each complaint that your patient has. And so we'll take the basic 7 and then we'll move from there and say, how can we apply it to our patient and make it applicable? One of my main goals today is to teach you, first of all, how to assess your patient. Second of all, what kind of questions to ask. Okay, so at this point, we've discussed 2 main forms of assessment. So now let's look at abnormal joint findings and see what we do with them and how we assess these abnormalities. So when assessing pain, really the easiest thing to do, rather than saying, hey, where's your pain? Well, it's in my spine, about halfway down, or maybe a little bit up and a little to the left. Have them point to it. That's the quickest, easiest thing. They say, oh, right here. Oh, right here. And so always have your patient point to where it hurts, and that'll save so much time and so much confusion. So that's the first thing you can do. The second thing you want to do with pain is say, when does it hurt? Morning, evening, when you move, when you sit down. When does it hurt? What do you do that makes it hurt? What do you do that makes it better? So those talk about, relieving symptoms and aggravating factors, things like that. Let's see. So have them point to it. You inspect that joint. So that's, inspection. Look at it. Is it red? Is it warm? What's going on with the joint? How badly does it hurt? So how bad is the pain? That's assessing their severity. Is it affecting your daily activities? Is it keeping you up at night? If it is, it's very severe and they need to get it checked out or they need to have immediate treatment for it. So depending on severity, that will depend what you tell the patient in terms of treatment. You want to assess their bone deformities. So how would you do that? You would look and you would palpate and you would feel. And so if they have bone spurs, you can feel that. A bone spur is like a bony nodule on the actual joint. It's connected to the bone. That differs from a cyst. I don't know if you guys have ever seen a cyst, but a cyst is like a fluid-filled pocket of underneath the skin, usually on the hand, and that you can kind of move around. A bone spur you cannot move around. It's on the joint, and so those are kind of the difference there. You can look for dislocations like the shoulder or the elbow. Did you dislocate a joint? And then contractures. So contractures are physical, permanent shortening of the muscle. And that's one of those things where you can kind of see that they just don't look symmetrical. One side does not quite match the other. You want to assess range of motion. So are they able, like Sean, was he able to move everything, move his arms appropriately? Can they move in all directions? Does he have any pain when he moves? That's, affecting his range of motion. So that's more inspection. You can have them move the joint and listen. So we talked about crepitus. And crepitus is cracking or popping when they move the joint. So we saw in the jaw that can happen. In the knee, mine does that. And so that's called crepitus. Now, if you're going to ask a patient about crepitus, are you going to go, do you have crepitus? And they're going to look at you and go, huh? What? So you don't say crepitus. You say, do you have popping when you move your joint? And they can say yes or no. Typically they know. Do you have popping in your jaw? Well, yeah, I do. And then you can assess their muscle strength. If they have muscle atrophy, maybe they've got a more serious condition. Okay, so this brings us to our first case. We do have cases throughout. Part of that is because the lab is included. And part of it, too, is to get you guys involved. So the 17-year-old guy comes in to your pharmacy. Big, strapping, young 17-year-old high school student comes in, and he's complaining, man, my arm just hurts so bad. I was working today, and I got to lift these boxes, because if I don't work, I'm going to get fired. So I pick up the boxes and put them on the shelf. But I can't do that because my arm hurts. So what's wrong with him? Does anybody know? We don't know. We have to ask him more questions. Okay, so we'll go back. What kind of questions do you want to ask him?
Point to where it hurts.
Point to where it hurts. Well, it hurts right about here. So right in my shoulder. I'm hearing mumbling. So what else do you want to ask him? When did it start? Well, it started last night. Oh, what was I doing last night? Man, I had a baseball game. We won, by the way. I play pretty hard because I'm like the best guy on the team, of course. And so, I'm hitting the ball, and maybe I might have overdid it. I might have. I probably did. It's a sharp pain. I mean, it started last night after that game, and it's been hurting ever since. Ice. I've been icing it. But, I can't ice it at work because I got to work. And if I don't work, I won't get paid. Money's important because I got this girl. Okay. All right, what else do you want to ask him? Northwest.
I don't have a question. I just want to know if Little Rock can push their button so we can hear their questions.
Yes, they can. Little Rock, push your buttons. Okay, what else do you want to assess in him? You want to look at the joint. Is it warm? Is it hot? Is it swollen? Maybe, sometimes when you get acute trauma, it's swollen. What else? To assess for maybe other diseases, just in case it's not trauma. Is it popping? Do you have muscle atrophy that maybe could be for, neurologic disorder? Any range of motion issues? Well, yeah, it hurts when I try to lift these boxes. I can't lift them all the way because it hurts so bad. So based on this, what do we think happened? We've asked him a lot of questions. I mean, yeah, sounds like he strained his muscle. So it's a pretty straightforward case, but you have to know what to ask and how to ask it in a way that he understands. All right, good job. Oh, shoot. Oh, well, okay. I already showed you the next part. It's supposed to be a surprise. So I want to mention a few specific musculoskeletal diseases and then how we as pharmacists could assess them. So the first one I wanted to mention is carpal tunnel syndrome. And, I'm sure everybody knows somebody that has carpal tunnel syndrome from typing all the time or whatever. So you have a patient that comes in and they think they have it. What are you going to do to assess them? So I'll show you a few things you can do. The first thing, it's back on here. It's not working. Y'all can hear me breathing. Okay. The first thing you can do is have them put their arms like this. So go ahead and do that because I know you want to. Like this. Yeah, very good. We all look so educated. So when they do that, they will have tingling and numbness. And so that's one of the ways you can tell if they have carpal tunnel syndrome. Another thing you can do is have them put their hand out and you can press down right here on the median nerve and they'll have those same kind of symptoms. So those are two things you can do if you think your patient has carpal tunnel syndrome. The next thing I want to talk about is assessing their pain, like ankle pain. Hey, my ankle really hurts. Well, how do you know if it's arthritic pain versus joint trauma, that kind of thing pain? And so if it's arthritic pain, no matter how they move it, it's going to hurt. And I don't know, Northwest may not be able to see. How they move it, it's going to hurt. If it's trauma pain or injury, that kind of thing, it'll hurt worst when they stretch the ligament. And that's when it's going to hurt worse. So that's how you know the difference there. They can have mid-back pain, so that can be because of posture issues or because of strain, maybe because of their work situation. And mid-back pain is very, very common, as well as lower back pain. But think about when you sit and study all day, when you're sitting there and you're at the computer or whatever, how do you sit? Do you sit like this, very posture? No, you sit over like this. And so this is what your skeleton looks like. And see how that could cause, I know that, and that's what I look like sitting at my desk. So that can cause, mid-back pain, and that happens in a lot of people. And then lastly, I want to talk about lower back pain on this slide, and usually that comes from disc issues. Lower back pain is so common. It can be very acute, lasting only a few months, or it can be very chronic, lasting even lifetime. So there's several different kinds of disc issues that could cause pain. So the top, I really like this image. The first one shows a normal disc. Everything's very uniform, very symmetrical. It's the same size as, the vertebrae above and below it, very uniform. But as, maybe as we have trauma, slow progressive trauma, or even just as we, wear and tear on our body, we can get disc degeneration. And that's not normal. And so it would be different from a car accident. A car accident or an acute trauma would not cause it, but slow progressive trauma can cause disc degeneration. The next one you see is a bulging disc. And a bulging disc can range all the way from asymptomatic, no symptoms whatsoever, all the way to disability. And that all depends on if the bulging disc puts any pressure on the surrounding nerve. And the more pressure it puts on the nerve, the more symptoms and the more pain it causes. A herniated disc is also known as a slip disc or a ruptured disc. And so you may hear called that more in the lay public than herniated disc. But this is one of the main causes of sciatica or sciatic nerve pain. A thinning disc is caused just by natural wear and tear on the body as we age. Our body, those discs don't hold as much water in their fluid cavities, in their little gel-like center, and so they get thinner. And then lastly is degeneration with osteophyte formation. So it's kind of like a spur, but it's smaller. So like I said, sciatica comes from a herniated disc. And so this is a side view of that. So you've got this herniated disc that's pressing against the nerve, and it causes pain that radiates from that point all the way down the leg, even into the foot and the toes. Very, very uncomfortable pain. From a clinical standpoint, I thought it was important that you know what the vertebrae are called, where they are in the body, and because for two reasons. First of all, I mean, it's important to know the body because you're a pharmacist and you're in the healthcare profession. But second of all, from an inpatient standpoint, from a clinical standpoint, when the physician talks about it, you need to know where it is. And I'll give you a few examples. Last month, I was working with multiple myeloma patients. And so I had missed a day because I was in another clinic, and so I came back, and the physician was kind of filling me in on what had happened the day before. And so he was talking about this patient. He said, yeah, she's got a sacral wound. Of course, sacral, well, you have to know where the sacrum is. And so knowing where that was, knowing that that was kind of near the tailbone area, allowed me to think, oh, maybe it's kind of a bed sore type wound, and we need to give something like zinc oxide, a protectant, to heal it, or not to heal it, but to keep it from getting worse. That same patient had, so with multiple myeloma, they've got major issues to the bones. They have very, very weak bones. And so when they were doing some of her scans to diagnose her and see how far she was, they found out that her T9 vertebrae was missing. It's gone. And so they had to go in from the front and from the back and put plates on both sides and cement and fix it all up. Well, from my standpoint, that's really important to know where the T9 vertebrae is. Is it up here? Is it down here? Is it somewhere in the middle? And that way I know going in what to expect to see from her, where the scar would be and that kind of thing, and even from a recuperation standpoint. And so first of all, the cervical vertebrae is up top. There's 7 of them. And then thoracic is below that, kind of in the middle, the mid-back area. There's 12. Lumbar is below that. So lumbar is like your lower back. And I think that's probably the most commonly known one. And then you have the sacral area. This image here shows that if you get injury to one of those vertebrae, where that would radiate throughout the body. For example, some of the ones up here in the neck can even radiate all the way down the arm if they get injured. And so that's important, I thought, to know, where the injury occurs and where it's going to be affected and what kind of complaints you're going to see from your patients. Okay, so there's 2 main classifications for musculoskeletal diseases, localized and systemic. Localized would be like osteoarthritis. It's only in maybe one or a few joints, so very localized to one specific area, typically the weight-bearing muscles or the weight-bearing joints. Versus rheumatoid arthritis, which is going to be a lot of joints, it's symmetrical, so it's on both sides. Osteomyelitis, that's an infection of the bone, one area of the bone. Versus osteoporosis affects the whole body, all the bones, and their mineral density. Throughout this lecture, we will discuss a few of them in a little bit more detail, starting with rheumatoid arthritis. So rheumatoid arthritis is a systemic inflammatory disease that affects the synovial tissue. The cause is unknown, but they think that it may have an infectious origin, but they're not sure. And so because of that, we cannot really assess risk factors. We know it's more common in women. We know that as you age, it becomes more frequent, but we're not positive on other risk factors throughout life. One of the main symptoms that you'll get from your patients is stiffness. And the way that differs from osteoarthritis is their stiffness lasts greater than 60 minutes. So they wake up in the morning, they're so stiff, and it lasts for at least an hour. Other things you may find are subcutaneous nodules. I've included a picture, and it may be easier to see on your slides, of what the hands of somebody with rheumatoid arthritis will look like. And of this joint right here, you'll have flexion and then hyperflexion of the second set of joints. So you can see that that's called Boutonniere's deformity. Another big thing about rheumatoid arthritis is that it's symmetric. So on this side of the body and the other, symmetric. That differs from osteoarthritis, which is also called degenerative joint disease. And it's characterized by articular cartilage and new formation of the bone at the surfaces of the joint. So its main differing in symptoms is that the stiffness in these patients lasts less than 15 minutes. So yeah, I wake up in the morning, I'm stiff, but it goes away once I get up and get moving. So that's the main difference there. Risk factors for osteoarthritis include age, history of fracture, history of trauma, history of infection. And so we're able to, maybe give some risk factors there. Obesity and also stress from like the patient's occupation or sports are controversial. So may or may not be a cause. So let's see what happened with this patient. In this patient, we've got a 47-year-old man. He comes into your pharmacy to pick up his monthly prescriptions. Why he's there? He just complains of stiffness. I got stiffness all over. I don't know what's going on. I take aspirin. It kind of helps. What's wrong with me? What's going on? So do we know? No, we don't know what's going on. But what kind of questions do we want to ask him?
When does it hurt?
When does it hurt? Man, well, I've been, when I wake up in the mornings, I'm stiff. I'm stiff for for quite a while. I get up and I eat breakfast and I'm still stiff and I get ready for work and it's still just kind of stiff. So it lasts, I would say, a good hour and a half. And the question was, how long? I gotcha. Okay, what other questions do you want to ask him?
Where does it hurt?
Where does it hurt?
Your hands? Is it your knees? Is it your hips?
Yeah, it hurts. It hurts mostly in my hands. Is where a lot of the pain is, both hands, and even in my knees and my feet. Both of them really, though. So we can ask him if it's chronic or if it's sporadic. Does it come and go? It's chronic. It's been there for a while. It's there every day. The more we talk, the faster it goes. The faster you can get out of here.
What makes it better?
What makes it better? Not really a whole lot other than just it just takes time every day. Aspirin helps a little bit, but really it just takes time.
What's the pain like?
The pain, mostly it's the stiffness. It's kind of a dull pain. It's not really sharp ever. It's just kind of this dull, aching pain. What else could we ask? We've asked if it's symmetric. Yeah.
Is there anything that makes it worse?
Anything that makes it worse? No. Really just when I get up in the morning, it's horrible. I'm stiff and I feel like I just can't move, and it's, ugh. What about muscle atrophy? Does he have any muscle atrophy? No muscle atrophy. So what do you think he's got? Rheumatoid arthritis, yeah. So we've asked enough questions. We've asked the right questions to help him figure out what he's got. So a little therapeutics. At this point, what would you do? DMARDs, NSAIDs. Yeah, and tell him he has to go to the doctor to get, the non-symptomatic, control. Very good. Okay, next up is osteoporosis. So osteoporosis is characterized by low bone mass and also by deterioration of the bone, leading to bone fragility, increased risk for fracture. It's estimated that 50% of people in the U.S. have over the age of 50 have low bone mass. And so, usually it happens in postmenopausal women, but it also can be multifactorial, just based on trauma to the bone over the years. And so risk factors that we can manage would be, the way that your patient eats, having calcium and vitamin D in their diet, stopping smoking, weight loss, exercise, or not weight loss, but exercise. And then also treatment, calcitonin, bisphosphonates, and other medications like that. And so one thing that I thought was interesting that I hadn't realized before preparing for this lecture is depression and low self-esteem in these patients. They have physical changes about them. They have a shortened stature. They look frail. They look fragile. And so depression and low self-esteem is something that I hadn't realized could be a symptom. The other things that you would look for would be the dorsal kyphosis. So that's the more hunched back that you could see in a lot of people with osteoporosis, as well as the cervical lordosis. And so that is where the small of the back, goes inward, curves inward. So this is a systemic disease versus osteomyelitis, which is localized. It's an inflammation of the bone marrow and the surrounding bone caused by an infectious organism. It occurs in the bone and often leads to very serious morbidity. So these patients get very sick. The bone can be infected by 3 different routes. So hematogenous, so it, infection gets in the blood and it goes to the bone. They can be infected by a site near it or next to it, and so you've got an infection right outside the bone, and it actually gets to the bone and infects the bone. The third way it could be infected is from, through the vascular system. So the vascular system is insufficient, and then the infection can spread that way. The most common organism that causes this infection is Staph aureus, although gram-negatives and anaerobes can also be common as well. But Staph aureus is going to be the main one. Things you would look for would be fever, tenderness, another infection that could be causing the bone infection. They can have drainage or limited motion. If you suspect these, then you would look for an increased ESR, increased white blood cells, and you could also do things like x-rays to figure out what's going on. Okay, so let's do another case. Okay, so you're on morning rounds, and this looks at it from a clinical standpoint, and hopefully you can kind of see what I do in the mornings as I'm preparing patients.
It might be a good time to take a break because we've only got 5 minutes, and do you mind taking a break now?
Yeah, that'd be good. Take a break now, and we'll do the case afterwards.